This is Susie Penman on July 7th, 2025 in Dallas, Texas on the SMU campus, conducting an interview for the Global Oral History of PEPFAR project. So to begin, could you just start off by introducing yourself, telling us a little bit about who you are?
Sure. Hi, good morning. I'm Michael Mizwa. I am the Director of Global Health for Texas Children's Hospital and the Chief Executive Officer for Baylor College of Medicine Global Health, based in Houston.
And so we will begin at the beginning. Can you just tell us a little bit about yourself, your family, kind of a little bit more about who you are?
Sure. I'm a native Texan. I was born in Austin, along with my twin sister. And I have a younger brother, older brother. We all reside in Houston, still in our extended families as well. And I have a beautiful wife of 27 years, and we have one son, Will, who is on the backside of his surgery residency at University of California, San Diego. So, yeah.
And let's talk a little bit about your career background. Tell me how you came to work on issues surrounding HIV/AIDS treatment and policy.
It's interesting. In the mid-'80s, I was actually working for a faith-based nonprofit residential substance abuse program in Houston, and it was really its core its core patient population, if you will, were recently released, incarcerated, and homeless, disenfranchised men and women. And I was an administrative director, one of a number of directors, and we had a close working relationship with AIDS Foundation Houston, which would provide periodically referrals from patients or beneficiaries of their social services, as well as other AIDS service organizations. And in 1987, we got a referral for a couple, two males, two guys, who were ill. They had clinical AIDS, and they wanted to end they wanted to be sober for end of life. They wanted to get sober and be able to be together through a sober period of time. So we took them into the program at no cost and detoxed them, and they started on their treatment journey. And sometime later, we were called in by the chair of the board, who just basically said we were fired. We lost our jobs. We were all terminated because we had allowed these homosexuals into the treatment program without consultation or approval by the board. And we're basically told that AIDS was a divine judgment by God against these immoral people. And so I called the executive director of AIDS Foundation, said, don't send any more clients over to this organization. I'll go unnamed. It's no longer in business, but I'll want to protect the program. And he said, well, Mike, what are you going to do? I said, I don't know. I'll figure something out. He said, well, we just received a CDC grant to do outreach and working with high-risk youth and homeless populations, substance abusers. Why don't you come over and we can talk about, see if you want something that would interest you. And I did, and I got a job. I was the first. I was the only heterosexual, the only straight guy at AIDS Foundation in 1987. But it was fantastic. I loved it and loved the people I worked with and the work I got to do. So, yeah, through through crisis came opportunity for me.
And through your work before that at this faith-based
Mm-hmm.
organization, what was your understanding of what HIV and AIDS looked like in Houston at the time? What?
Well, growing up in Houston, I mean, at that time, the reality was and I didn't know this until I began working at the foundation, but Houston was an epicenter for HIV disease. Unbeknownst to me, we had a very large, significant LGBTQ community in Houston, and because of the large and pretty robust gay community, we, like New York, LA, San Francisco, Miami, were hard hit by the epidemic, and I didn't fully grasp that until I went to work for the foundation. And although I didn't work within the gay community itself, obviously, I was out trying to prevent HIV infections just in general, especially with high-risk youth, homeless, substance abusers, commercial sex workers, et cetera. So it was an interesting time, and I think that at that time in Houston, outside the gay community, probably very little knowledge and understanding. That lack of knowledge, I think, translated to fear, stigma, discrimination. I mean, similar to what we saw early on with COVID, I think. So it was an interesting time to be out trying to inform, dispel misconceptions, and really try and promote the messages around prevention, which was, latex is my friend, and monogamy, as well as just abstaining from any sexual or high-risk injection drug use. So that was kind of my path for many years with the foundation.
Can you tell us more about your path? Because you were there for 17
years. Yeah. So, when I started in 87, 88, it was a large volunteer-driven organization, just like most AIDS service organizations at the time in Houston. And AIDS Foundation was, to my knowledge, the first nonprofit AIDS service organization that was created specifically for HIV services. It was formulated in 1982, and so it was a grassroots organization. Volunteers helped provide services. We were a social service organization. We didn't provide medical care. And we had, at that time, probably a staff of, I don't know, maybe 15 at the most. And our funding came primarily from just private philanthropy and donations. And over time, as we started to see Ryan White Care Act engaged and operationalized, and more funding coming from the U.S. government, the city, the state, et cetera, we started providing housing opportunities for people living with HIV/AIDS. And then, so I was involved not only on the prevention side and education, but then ultimately virtually all education that we did across the full strata of communities and populations, and ultimately started working within the Texas Department of Criminal Justice, and which was unique at the time. They had never allowed outside organizations or individuals to come in and talk about HIV prevention, advocating for condom use or latex, because at the time, it was prohibited within the Texas Department of Criminal Justice, the distribution of condoms. So you could discuss but not distribute, and you can discuss but not demonstrate, because we weren't allowed to have contraband in in the prisons. But we created a award-winning training of trainers program where we were able to. We had a 40-hour curriculum. We met with individual prison wardens who would select sort of key stakeholders, leaders within their system that we would train over the course of this training of trainers program to train the offenders themselves to do their own HIV education and sexually transmitted infection education within that particular system. It's a very empowering program, which I've found extremely rewarding, both in the male population prisons as well as the female population prisons in Texas. So, and I think that program is still going on today within the foundation.
I just have a logistical question. Did you all advocate for condoms to be allowed within prisons then?
No. I mean, one thing that I learned at the foundation, and you learn very quickly, there's advocacy, and there is service delivery. And for us, knowing and appreciating and respecting where the line is, where the boundaries are, and that has carried over, obviously, in global health work. But to be able to get a foot in the door and actually be able to operationalize something like this meant that there might be compromise, not compromise in content necessarily, but compromise in delivery and what you can and can't do, and respecting the system and policies and procedures. So that was another fight for another day for other people. We were very, very grateful to be able to go in and do education, which was something that couldn't be taken away from these men or women. They felt empowered, and I think very much respected for being able to not only learn this information, but to share it with their peers. So, yeah, we were very very respectful of our relationships with the Texas Department of Criminal Justice, and at that time, the health system within Texas Department of Criminal Justice (TDCJ) was managed and facilitated and overseen by the University of Texas (UTMB). And so they were our medical partner as well. So we were dancing with two different partners, trying to appreciate, understand, and respect different systems, institutions, and policies on both sides. And I think we did that quite well. Yeah.
And I imagine over the course of your 17 years there, AFH, is growing rapidly from its 15 max people. Can you talk a little bit about how
the growth and the trajectory?
Yeah, as AIDS became a
yes. In the probably for the first 7 years I was there, we had 7 executive directors. It was a hard place to work, meaning not difficult in the job, but difficult in culture and environment. It was AZT was not even an approved drug. There were no antiretrovirals, and I recall the first couple of years. Every Friday was we had these little magazines that would be delivered to the front door of the foundation called "This Week in Texas," a little community magazine type of piece, and the first thing everyone did was flip to the back where the obits were to see who had passed away over the past week. And a lot of our staff and many volunteers were living with HIV, had been shunned by family. Their partners had passed away, living alone, working alone, and in many cases passing away alone. And so it was a difficult environment to work in because there wasn't a whole lot of hope in the early days. And for those of my colleagues and others that were working in the early 80s, even more so. And that's not an environment that's conducive for long-term leadership, I don't think. So for a number of reasons, we had a sort of a revolving door of executive directors, and we finally landed on a executive director, Sarah Selber, who literally she put us on a trajectory that actually allowed us to not only grow but expand and really become an organization that was truly functional, operational. She embraced monitoring and evaluation as a way of ensuring that we could provide data to our donors to show what efficacy, what not just widgets, not just people served, but what type of health outcomes, what type of level of satisfaction in social services, putting in financial best practices, HR best practices. I mean, really creating and moving AFH from a kind of a grassroots volunteer-driven organization to a 501c3, a nonprofit that could be reckoned with. And with those changes came new funding and levels of funding that we had never experienced before. Multi-million-dollar foundation grants, multi-million-dollar federal and county and state grants for housing, to build new projects, to start programs like camp, and to continue our Wall Talk program in prison through HRSA. And it just we suddenly became a very large, robust organization that it was a really neat place to work. And that's how I left it. And I was able to, I actually, right after Sarah began, I was burned out, fried. I just got married, and we took a year off. I asked to take a year off. I just wanted to charge my batteries. Our son was 3 or 4 at the time. And they said, yes, take a year off, come back, but you have to commit to X number of more years, but go charge your battery. So we packed everything up, moved to Grenada in the West Indies for a year, and just chilled as a family, and kind of like a Corona commercial. And believe it or not, and came back, and it was it was off to the races.
Yeah, how did you come back?
After that? Well, I came back pretty energized and ready to go. And as they say, piss and vinegar. And the folks around me are like, Mike, chill out. We haven't been off a year, so you just need to slow down and, let us catch up to, where you are. But we had a lot of neat things happen at that point around camp and some other projects, and it was pretty fabulous.
You keep mentioning camp, and I wanted to ask you about that. Can you tell us about Camp Hope, which is what I assume you're referencing here?
Yeah. So now it's probably almost 30 years ago. I got to it's kind of it's a segue into how I sort of ultimately found my way to Baylor College of Medicine. But I'd been working with a young infectious disease pediatrician, Mark Klein, at Texas Children's in Baylor College of Medicine, and he oversaw a pediatric AIDS clinical trial group and had a community advisory committee that I was on as a representative at AIDS Foundation Houston. And he and I, we got to know each other pretty well. And one of his patients, by the name of Corel, whose mother had died, was being raised by a grandmother, came to me because she was also receiving social services from AIDS Foundation Houston, medical services or clinical trials at Texas Children's. So Dr. Klein was doing the medical side of interventions with children, and we on the social services side were providing assistance with rent, food, subsidies, whatever it may be to help the family. And Carell's grandmother, Nona James, came one day and said, I'd like Carell to be able to go to camp. She's always wanted to go to camp, but every camp I call, they say she can't go because she has AIDS, and you got to do something about it. And we started talking about it, and our Sarah Silver at AIDS Foundation said, just do it. I mean, long before the Nike. She's like, go do it. Raising money, finding the funds is the easy part. So I sat down with Mark. We started talking about it. We designed a program, found a facility at Camp for All outside of Brenham, Texas, which is designed for special needs populations and still operational today. And we started Camp Hope, which was the first camp of its type in this part of the United States for specifically for children with HIV. It was a 1-week sleepover camp, and we started doing it, and it grew and grew and grew. We had children from all over Texas, Louisiana, Florida, and elsewhere. And Dr. Klein, his team provided the medical support at camp, and AFH provided the funding and the volunteers, and it was a beautiful partnership. And we got to know each other pretty well in doing that project. And the beauty of it is that like anything pediatric HIV, we want to go out of business. I mean, that's the ultimate goal is the day that we don't have camp for children, because there are no more children being born and growing into with HIV disease that are eligible to go to camp. And we're pretty much there, which is it's a great thing. Yeah.
And we'll start to transition a little bit to your work with is it BPI?
Yep.
BPI.
Mm-hmm. Yeah.
With Baylor International Pediatrics. But I want to ask quickly, over the course of your 17 years at AFH, how is your understanding about the global HIV/AIDS situation evolving? Because you're so laser focused on Houston for this time.
Yeah, I was very laser focused on Houston and Texas, and to some degree the U.S., but more on specific populations. After Sarah left and I became CEO in around the year 2000. A lot of my focus was on incarcerated populations, primarily juveniles and adults, and I did a fellowship at CDC, a Price Fellowship around working with incarcerated populations and HIV prevention, and really started to work with a lot of different groups around the country that were trying to serve disenfranchised, incarcerated populations, and so outside that world globally, and outside our client population in Houston, which was at that time we were starting to see more and more men and women of color that we hadn't seen in the previous decade or so. So our client population was diversifying rapidly, but globally, I didn't have a clue of what was happening. Dr. Klein and I would have lunch periodically, and he told me that he was building a center and doing some work in Romania, and that was around 2001, but that was sort of a one-off type of situation where a lot of children had been infected through nosocomial infection, meaning contaminated blood products, et cetera. But I had no idea what was happening in Africa. It just was not part of my the optics of anything that I was working in.
Yeah.
And and then around that same time, I don't know, 2000, 2001, I'd come back from Grenada. I teamed up with Dr. Klein again, not around camp, but AIDS Foundation had begun doing a lot of housing for people living with HIV that were either homeless or families. We actually built a complex with funds from the Houston Endowment Foundation for women HIV-infected women that had children who were homeless, to try and help them be able to empower them to go back to school, become employed, be able to actually get antiretrovirals and really be able to maintain and stabilize their family situation as a transition into their own personal sustainability. And we were talking about Habitat for Humanity one day and said, "Wow, why don't we see if we can build habitat homes for HIV positive families?" And we approached the Houston chapter of Habitat for Humanity. They said it's never been done anywhere in the world. It's something they have not really embraced due to risks of, or perceptions of risk of infection, because sweat equity is part of the process. The families actually have to contribute hours to build the house. And so we met with Habitat for Humanity many, many times, their board, and finally got a green light to build a Habitat for Humanity home specifically for an HIV-positive family. And Mark helped raise the money, and we put the volunteers together, and we did this pretty complex process of selecting families that would apply for one, and we did it. And we built one, but we built two over the course of about 3 years, homes for the first homes for families living with HIV. And so it was yet another contribution where we as a social service organization were partnering with Texas Children's and Baylor and Dr. Klein on the medical side to try and improve and empower what we thought were inequities within the HIV community in Houston. And it really created a pretty solid friendship between us. So, yeah.
And tell us about how that led to you officially joining Baylor College of Medicine.
Yeah. I after BPI opened its Romania clinic, I would have lunch and catch up with Mark when we weren't building houses or doing camp or whatever. I'd hear about the neat things he was doing globally, and he said, "Hey, we've got some funding. We're going to be building a center in Botswana," and that really piqued my interest. And after it opened in June 2003, we started talking, and I said, "This is really neat. What would I love my job and I love working at the foundation, but how can I potentially be part of your team? Do you have a vision moving this forward, or is this going to be, what your global enterprise is going to look like?" And he had a vision of securing funds and building other pediatric children's centers of excellence in the region. And we talked and talked for almost a year, and he finally said, he came over for dinner with Mary, my wife, and I, and he basically said, and he did say this, he said, "I need you to fish or cut bait," meaning let's quit talking about it and make a decision. And it was a difficult decision in that I knew I was going to be traveling away from my family, but it was something that was very exciting, something that I felt I could really, it was a dream that would be something that really meant a lot to me. And I did. I said, I'm going to fish. And yeah, I started pretty, I don't know, I think I gave, 3 months notice or whatever, maybe longer than that, I hope. And I started on May 1st, 2004. I did orientation at Baylor, and on May 2nd, I was on a plane to Africa, and I didn't come home for 3 months due to just situations that kind of helped drive and define my role within BPI.
Mm-hmm. Tell us about that first trip.
Yeah.
That was it supposed to be 3 months?
2 weeks.
Yeah.
Yeah.
Tell us about that. And was that
Yeah.
your first time on the continent?
No, I actually had gone to Durban, South Africa in 2000 to the International AIDS Conference and presented a poster actually on Project Porchlight, which was our habitat project, which was pretty neat. So that was my first trip to Africa and my only trip up till then. Yeah, I met some colleagues in Botswana, and I was kind of just it's sort of part of my in-country orientation, seeing the sites, seeing the programs. I had been to Romania already with Mark and the team before I started with BPI. It's been on a kind of a network meeting, if you will, earlier that year. And a few days before I was about to go home, he called and said, "Hey, we have a situation in Romania. The county health department has shuttered the clinic. They've confiscated our antiretrovirals, our medical records. They've padlocked the doors. We don't have access to the clinic or patient care. Can you meet me in Bucharest?" And I was in Uganda, and changed my ticket, met him in Bucharest, and started meeting with the embassy, State Department folks. Ended up going to Costanza, meeting with health officials and trying to understand what the situation was. And it was blowback between the organization that we were subcontracting with for care and treatment. We were providing another local organization funds to provide the clinical care within the clinic setting that we had helped raise money for to build. Meaning, we really had little control over that organization, its practices, its organizational practices, I should say, and it had a falling out with government. And by virtue of that relationship, government shut the clinic down, and we were sort of caught between a rock and a hard spot. And I stayed there. There was an apartment in the clinic, and started to help try and sort out and figure out not only how to open the clinic up, but how can we resolve this impasse of putting all of our funding and resources into organizations that we have a relationship with, but have no control over. And we ultimately landed on the creation of the desire to create our own nonprofit, our own NGO in Romania, which had never been done before. And that became our model by happenstance, by that crisis creating an opportunity for us to create our own legal framework that we would have complete control over as far as best practices, as far as policies, procedures, quality of clinical care, relationships with government, financial transparency, reporting transparency, and really being able to show donors as well as our partners on the ground that this is an extension of us in every way, shape, or form, both Baylor College of Medicine, Department of Pediatrics, as well as Texas Children's Hospital. And therein, my experience, obviously, in working in the nonprofit world and not academic medicine, and 17 years at AFH, and understanding the nuances of bylaws and nonprofit systems, et cetera, was quite beneficial. It sort of redirected my job within BPI, which was I was hired as the director of special projects, and that's usually kind of a catch-all of don't really know what you're going to do, but we'll figure it out. And that was a special project, and yeah, it took us about almost a year to get it fully operationalized and transition assets and staff and create a legal framework. And I spent pretty much that year in Romania. Yeah.
It seems to me like the theme emerging here is the way you gathered experience in navigating really complex partnerships between very different organizations. And this seemed to begin at AFH. And so can you talk a little bit about how your work domestically did sort of prepare you for your work internationally?
Well, yeah. So I mean, I don't know. Unlike the rest of my most of my colleagues who had backgrounds in public health or actually in medicine, I did not. I was an anomaly, I guess, on the team. And working in an AIDS service organization in the mid to late 80s and the 90s, it was a time when I worked in an organization that was, I would say, for the most part, we had a lot of fun. It was unfiltered. It was it was yeah. It was no holds barred type of an organization, and I'll leave it at that there. And but what I came to learn very quickly was and I can totally appreciate this from my family and my parents, and in raising myself and my siblings as respecting all people for who they are, regardless of race, creed, religion, color, and now sexual orientation, which I'd never been exposed to until I started working at the foundation, and understanding that there are a lot of different ways of not only providing services, but how it's received, how it's heard, how it's communicated, and being respectful of partnerships. And partnerships are based on people. And Dr. Klein was very much of that, a leader in that right of understanding, respecting partnerships on the ground, and not trying to Baylor or Texas childrenize a service or a program, but trying to us adapt our programs and our culture and our way of creating and running organizations to the local context. And I think that has been that was extremely beneficial for me. Not embracing something here in Houston or in Texas or in the U.S. and trying to force it into a round peg in a square hole. But going into these partnerships, eyes, ears, and mind wide open to not only mutually address a situation, but try and find the common themes and the shared principles and values that would make the partnership work. And it I think has allowed us to succeed for so many years in our partnerships, not only in Africa, but in South America, as well as Romania and now even in Ukraine. So
I'm glad you mentioned that, because I wanted to ask about BPI's partnerships, and it's the affiliated and independent NGOs that y'all work with across the different countries where you are. Can you talk about, well, a couple of questions here. Talk broadly about those NGOs, how they work under the BPI umbrella, how they were chosen, and just thinking ahead a little bit, because a big part of PEPFAR, of course, is sort of establishing these partnerships in country, and shifting a lot of the, I guess, agency to these in-country partnerships, making sure they're local.
Yeah.
Can you talk about that?
It's a great question. wish I could say we had a crystal ball and knew that PEPFAR was even going to be something, because um, I started at Baylor a year after PEPFAR, and we still kind of new to me. But when we created the Baylor Black Sea Foundation in Romania, which was our first NGO, it was created as a legal subsidiary of Baylor College of Medicine. That was the only way we could create that legal enterprise, if you will, was to have it affiliated with another legal entity. And so we had representation as founding board members as part of the governance structure, as well as the ability to receive and help in making determinations and decisions in respect to policies, procedures, and best practices. So that was 2004. That was our first legal entity that allowed us to hire our own staff, own assets, pay taxes in country, manage and build, and this clinic operation that we had in Constanța, Romania. So we operated clinical infrastructure. We didn't just put people into a hospital system and operate. We created a legal entity with a brand, with a name, with an executive director, all local staff, and we provided the technical assistance for that organization to succeed. Technical assistance in clinical best practices, in financial management, HR policies within the local context, facilities management, philanthropy, fundraising, nuts to soup. The organization itself had the agreements and worked under within the partnership of the local government. So we were somewhat a degree removed as U.S. institutions, but we were the organizations themselves were directly associated, not only affiliated, but actually legal subsidiaries of Baylor College of Medicine. So that's how we started with that model. When we opened our center in Botswana, we did the same thing. We created a Botswana Baylor organization, a trust foundation there with a local executive director, so that we could operate the center that we had built, hire and train staff, receive funds from international donors, from government. And that foundation, the Botswana Baylor Trust, would then establish its relationship on our behalf and memorandums of agreement with government to receive funds to support those clinical operations. And we would become integrated then within the Ministry of Health Systems of Care. So what was unique about our program pre-PEPFAR was we were our public-private partnership model, which was securing private funding to build infrastructure, build necessary clinical infrastructure for pediatric HIV. Part of that would be with government negotiating our desire and ability to create a subsidiary non-government organization that would operate under an agreement with government to receive funds from government. The government's not going to give a U.S. institution money, but they'll give it to a local non-government organization. And that allowed us to operate under memorandums of agreement, shared principles and values with that foundation and government, and actually integrate our clinic operations and the children and families and the data. Everything became integrated within the Ministry of Health Systems of Care. We became an extension of the Ministry of Health, not an extension of Baylor or Texas Children's, but an extension of the Ministry of Health. And that was the model that I think Dr. Klein thought would be the most efficient, and we embraced that wholeheartedly. It wasn't easy all the time, but we felt that if we're gonna go and support a country, it's by invitation. We weren't parachuting in and saying, we're here, we have some money, we're going to help you solve your pediatric HIV program. It was typically by invitation. We would discuss and negotiate with ministries of health what the scope and breadth of their pediatric disease burden was, what resources could they bring to bear to support us, and it's part of a partnership. That's the public side of the public-private partnership. If we brought in private money to build infrastructure, could they support us on the public side with resources to support the operations, to funding for salaries? Could they provide the antiretrovirals, the lab support, et cetera, et cetera? And it started out in Botswana, as I've indicated, in 2003, and pre-PEPFAR, the funding on the African continent to address HIV, not just pediatrics, but HIV in general. It was corporate social investment by the pharmaceutical companies. Bristol Myers Squibb Foundation, the Abbott Fund were key donors of ours, not the pharmaceutical companies themselves, but the philanthropic entities of those companies whose mission was to provide philanthropy to support the public and private sectors in HIV. And so we were receiving private funds pre-PEPFAR to build infrastructure, and then negotiating with governments for subventions from ministries to support the operations. And that is really the model that ultimately started to translate how we found and picked and negotiate with other countries to build similar types of clinical operations.
So
it's pretty interesting, quite frankly.
Yeah, I want to know more about it. And this maybe is getting in the weeds a little bit, but it is really interesting. And thinking about BPI works in a lot of different countries now. And so thinking about it, what was it like to sit at the table, so to speak, if y'all actually did sit at a literal table with members of the local government and negotiate these sort of differences from country to country, ideas coming from y'all at BPI, and trying to keep an open mind about how to adapt things and make sure it's appropriate to the communities you're in and that kind of thing. I want to know all about that.
You know what was fascinating about Botswana. When BPI started in Romania, and its pediatric population, they initiated antiretrovirals to children, and immediately started to see declines in morbidity, mortality of children, and we instinctively knew that would happen, and that initial BPI initiative was a public-private partnership, and it was funded by the Abbott Fund, which was Abbott Pharmaceuticals' philanthropic arm, and they were very generous to us. And soon after we opened that center in 2001, the president of Botswana at the time, President Festus Mogai, who is still, and to this day, a very staunch advocate for HIV on the African continent. But he addressed the UN General Assembly in New York, and it was a call to action. He said, and I quote, "We're on the we're threatened with extinction." And at that time, Botswana had a 40 to 50% prevalence for the entire country, a country the size of Texas, with a population of about 1.5 million people. If that's kind of almost hard to fathom. Half of the population potentially living with HIV disease without access to care, treatment, antiretrovirals. And that call to action, we saw the Abbott Fund Step Forward program launched with hundreds of millions of dollars. Bristol Myers Squibb Secure the Future, launching similar levels of funding. Bill and Melinda Gates, the private philanthropy, corporate social investment responded to that call to action pre-PEPFAR. And we were able to secure funds from Bristol Myers Squibb Foundation to, based on our efficacy in Romania and our experience with pediatric HIV and Dr. Klein, and under the leadership of John DeMonte at Bristol Myers Squibb, we're able to secure funding for Botswana. We built the first Children's Pediatric HIV Center of Excellence on the African continent. I think there were naysayers that thought that due to stigma and that mothers wouldn't come, but it was just the opposite. Mothers did come, and it was magical. I think our ability to get mothers tested, mothers on treatment, and children on antiretrovirals, and we were able to ultimately embrace the government to help us with funding to support the center. Once the Bristol Myers Squibb Foundation money stepped down over the first 5 years, they picked it up with subventions and backfilled that support directly to the foundation, and that funding remains today. Actually, it's increased probably threefold over the past 2 decades to allow us to expand beyond HIV care and treatment to pediatric cancer. We're doing pediatric surgery and other integrated partnerships with the government of Botswana. So it was it allowed us with the private funding allowed us to have discussions with government based on what their needs were. Botswana was unique in that it did have at that time some resources to commit itself to HIV care and treatment, but no one was doing pediatrics, and we did. I think the other thing, the beauty about Botswana is our first country on the African continent for BPI. We were able to, not only through our partnership with the Ministry of Health, but they too brought us together with other academic institutions working in Botswana. So the shared principles and values around addressing the health inequities translated over academic institutions as well. So we had a strong relationship with Harvard, Botswana, and their lab infrastructure at the time. In UPenn, doing University of Pennsylvania, doing adult HIV care while we were complementing them on the pediatric side and working closely with them. So some of those partnerships grew and developed in the early years of the epidemic, and then translated on years later as well.
Mm-hmm.
So,
just a quick aside, sort of. Just you mentioning the word epidemic made me think after being in Houston, then of course Romania, but then coming to Botswana and seeing the way HIV/AIDS had worked its damage on the population.
yeah.
What was it like to see that after your extensive experience in Houston, going to the continent, seeing that?
It was sobering. There's it's hard to describe. I think for me, I had never worked with and been around sick children, and I had been a part of an experience, my fair share of dying and death of friends, colleagues, acquaintances in my days at AFH, but working in impoverished areas of sub-Saharan Africa and seeing sick mothers and children, and then ultimately working with the orphans and vulnerable children of whose parents were deceased, or being cared for by aunts, uncles, grandparents, etc. It was a very different world. I think for anybody that had not been working on the African continent and other areas of clinical health or humanitarian work, and so yeah, it was very different, and it really, I think, for all of us that were working on our team, and I think probably for every institution and organization working in this space at the time, we had our own personal calls to action. I think that it was there was a commonality. I think there was a thread. Maybe not DNA, but you knew the people around you, both our local staff as well as our U.S. and other expatriate colleagues, wanted to see an end to what we were seeing. We knew that it was what was rate limiting simply was resources. I think the beauty of PEPFAR was that suddenly there was an opportunity with resources to transform the global landscape of disease and suffering and new infections that I don't think we ever thought we would see in our lifetime. And it was magical. It was something beyond magical, I think, and I think it gave all of us quite a bit of hope, whether we were recipients of PEPFAR funding or not. And we weren't one of the big recipients of PEPFAR funding, but we were able to work with and engage with other organizations and institutions and obviously ministries of health that were truly benefiting from the technical support and the financial resources that the U.S. government brought to bear. Made you very proud to be an American. Still does make you very proud to be an American.
So you've talked a little bit about, prior to PEPFAR, how were BPI's global programs funded, which is this public, sort of complex network of public-private partnerships. Can you describe how, after PEPFAR was authorized, how that maybe changed the trajectory or strategy of BPI?
You know, we sat around a conference room at Texas Children's, Dr. Klein, and a number of our leaders, actually some folks from leaders from Romania and Botswana, Mexico, and then our team within the BPI itself, to talk about, after Botswana, post PEPFAR. This is 2004. If we had the funding, if we could secure additional funding from the Abbott Fund and Bristol Myers Squibb, which they had somewhat committed funding for, more infrastructure, where did we want to position ourselves? Botswana was one of the 15 priority countries identified early by PEPFAR. But we were already there, and we were not a recipient of PEPFAR funds for Botswana. We were operating under private philanthropy and as well as government subventions. So, an informed decision was made. Why don't we go to high burden countries in the region that are not designated as PEPFAR countries? Let's approach them. Let's put out a call and send some notices to ministries of health and see if they would respond to, if they would like to discuss or apply, if you will, for a children's clinical center in their country based on the burden of disease, prevalence, the ability to support with resources, et cetera. And Dr. Klein sent letters to different ministries of health in the region. Some responded, others did not. We started doing site visits by invitation of ministries of health. And long story short, our next two centers ended up being both in Swaziland and Lesotho. Swaziland now the Kingdom of Eswatini. Both as high a prevalence as Botswana, upwards of 39, 40%, much smaller countries, but similar population sizes, 1.5 million people, and also high rates of TB, but not a PEPFAR country, and we were fearful that without additional resources, it could be very difficult in those countries. And Bristol Myers Squibb stepped up to the plate. Again, they had funding for one center. After the site visits, the epidemics, their systems, really the landscape of disease were almost identical. And Dr. Klein and John Namonte agreed that we can't make that decision. We're not going to choose one over the other. Let's fund one in both. And we did. So in in 2005, we opened our centers in Eswatini and Lesotho, and also created our Baylor College of Medicine Children's Foundations there, sat down with the ministers of health as well as the ministers of finance, and negotiated prior to breaking ground and building the centers, if we create our affiliated foundations and we can provide the funding for the infrastructure to build these centers, and we can provide you with pediatricians to staff and train your health sector, can you support it financially through government subventions and integrate it into your Ministry of Health budgets and systems of care? And they both agreed, similar to Botswana. So our first 3 public-private partnerships that we were able to build infrastructure with private funds then were being funded operationally by government, and to this day. And so integrated into the health systems funded by government, the funding going directly to the local NGO or affiliated foundations. They're responsible for the reporting, the financials, and then they're also able to parlay that funding and as a foundational basis to secure other funds from other international donors, whether UNICEF, a big donor in all of our sites early on in the early days of the epidemic, Global Fund, other private funding, and then ultimately potentially subcontracts with PEPFAR recipients or prime awards as a foundation, local organization that was eligible for direct funding by PEPFAR. And that happened later on, before we ever knew that there was going to be a desire by PEPFAR to want to start funding more local driven entities, organizations, ministries, and less on U.S. academic institutions. So when I said we didn't have a crystal ball, we had actually positioned ourselves quite nicely to already have local affiliated organizations that were created as the basis to run our clinical infrastructure, and best practices that went with that to be positioned to apply for and receive ultimately direct funding from USAID, CDC, National Institutes of Health, or whatever the funding stream might have been for PEPFAR in that particular country.
But initially, PEPFAR helped y'all identify sort of gaps that existed in the moment. Is that
by defining what their tier 1 or priority countries were going to be early on, helped us determine what our priority countries were going to be to help really have a greater coverage of resources in countries that had not been identified as priority, but had very high burdens of disease. So it was actually quite complementary,
Yeah.
if you will. Yeah.
And so BPI has worked, of course, now has spread to a number of other countries. Can you talk about why those particular countries? And you've started to get at this a little bit, but
Yeah.
Beyond Eswatini and Lesotho.
Yeah. So after Eswatini and Lesotho, we were approached by Malawi, and at that time we met with the Ministry of Health in Malawi. We had a commitment, a pseudo commitment by the Abbott Fund to potentially help us to subsidize a center to build a center in Malawi, as well as provide operational support. And let me go back to, as I say that, in Romania, the Abbott funding that helped us rehabilitate and create our clinical center, our children's center there, Abbott was our sole source of operational funding. We didn't have support from government. Abbott was actually providing Baylor College of Medicine, which would then provide the foundation with the funding to support all its operations. So everything from staff to utilities, repair, nuts to soup on the operational support. And so we met with Malawi. Malawian government said we would love to have a center. We're one of the poorest countries on the continent. 80% of our health care is subsidized by foreign aid, and we cannot commit to providing you with financial resources that Lesotho, Botswana, and Eswatini have. We'll do everything we can to support you, but we can't provide you with financial resources. We will make this. We will embrace this partnership as no one has embraced a partnership. If you come help us, and it was truly a commitment of a willingness to be when they said that we'll be the best partner you possibly can. I think that we took that to heart, and it ultimately has resulted in us investing probably more by Baylor College of Medicine, Texas Children's, and private philanthropy in Malawi than we have in any other country in respect to service lines, diversification of services, et cetera, because the government truly has embraced a partnership. They've embraced agreements, they've embraced our local foundation, and they have just been delightful to work with. But we made that informed decision knowing that we as institutions, Abbott is a philanthropy, we would have to find resources to sustain this program. And I think one of the things that BPI was is a very staunch believer in the development of programs versus projects, meaning we were not in the business of one-offs. If someone came and said, we have a relationship in this country and we've been doing this or that, and we have some funding to do this for this short period of time, or a research project to do something for this amount of time, we typically would not embrace those types of partnerships or relationships. We really looked for program development, meaning the ability to create a legal framework that could integrate within ministries of health, that would be integrated and partner with governments so that it becomes part of the thread and cloth of the public health sector, And then that they would help us find resources. We would help them find resources, both in kind and financial, to sustain the program as long as there's a need for the program. So no real end date, and never really a quote a transition to government, because we created it as an extension of government. We see ourselves as part of government, not as a siloed entity that is some way separate of government. So if things go one way or one direction or another, we're going to just dump everything, dump the patient care services onto government. We've really tried to ensure that our systems are an extension of and integrated within Ministry of Health systems of care. Mm-hmm. So Malawi was one of those where we knew long term, if we do this, we're going to have to find funding and raise money. That was unique at the time. At the same time we were building our center in Malawi, we soon thereafter began building a center in Uganda, in Kampala, at Malago National Referral Hospital, building on a CDC-funded program we had with the Pediatric Infectious Diseases unit there. But we had not. It was we did not have any infrastructure. We were working out of a pretty dilapidated space for infectious disease with a lot of children. And Ambassador Jimmy Colker was the ambassador at the time, and a very much an advocate for PEPFAR resources to Uganda. He went on to lead UNICEF, and I think continues to this day to be quite an advocate in the HIV space. But Ambassador Colker, John Merman at CDC Uganda were very much keen on helping us and wooing us to find private funding to build a children's center, and that PEPFAR could help support us, support the local organization, the foundation, operationally. And that has become actually our largest program in the world, with seeing more patients and more U.S. government resources than any other program that we have. So we ended up, over the next couple of years, after Botswana, Lesotho, and Eswatini, those were the only three that we were able to integrate government resources from, as far as cash subventions. Uganda, Tanzania, which was fully subsidized by USAID on the public side. Uganda and Malawi were either private funding or PEPFAR, U.S. government subsidized funding. And so we ultimately ended up trying to address gaps, needs by invitation of governments, and in some cases even invitation by USAID in the case of Tanzania, to address gaps and needs. So our sort of our organizational, our NGO portfolios had a very diverse field of funding. Some, Uganda and Tanzania, for example, were almost exclusively U.S. government subsidized through different means, through different PEPFAR mechanisms, and global health security funding. Others more subventions from ministries of health, and then Malawi, a little of both. Significant funding from PEPFAR, USAID, to the local foundations, as well as continued private philanthropy for expansion of services far beyond HIV. And then some non-starters in other places around the world that in and of itself show that the best intentions and what you think are really solid models of implementation just don't always work out.
Can you talk more about those? These BPI centers of excellence that failed before they were able to really get off the ground.
Yeah. Yeah, the centers we have today in operation are primarily in sub-Saharan Africa. So Botswana, Lesotho, Eswatini, Malawi, Tanzania, Uganda. In Eswatini and Lesotho, we also received private funding to build satellite centers that look like little mini centers of excellence out in rural districts of the country to broaden our and disseminate care and treatment. We received funding, private funding, to build a center in Bobo Dioulasso, Burkina Faso, early, 2005. That is a public-private partnership. We created a local foundation. We had a commitment by government to support the operations once the center was built. And typically those centers, fully built and equipped, would cost in the neighborhood then of about $2.5 million US dollars. So we had that commitment from Bristol Myers Squibb Foundation. Unfortunately, over the 5 years that we were there, we had doctors on the ground, pediatric AIDS core physicians on the ground, actually providing care and treatment, waiting for the center to be built so that we could operationalize it. And after 5 years, the money was depleted. It was 50% complete, and we had to walk away simply because the funds had been, to some degree, after the fact, probably mismanaged. And I'll leave it at that. It was our contractors had ties at the time to high levels of government, and it gave us very little recourse. That was our only foray into a francophone country. We really wanted to have a center in West Africa. It never materialized. Around the same time, we had funding to build in Western Kenya, in Kisumu, Kenya. We created a local foundation there. We had doctors on the ground in Kisumu. I was actually living in Nairobi at the time. My family and I moved to Malawi in 2005 and lived there for a couple of years while we were building these centers, thinking I could spend more time with them. And in 2007, I guess, they went back to Houston. I went to Nairobi to help put this center up. And then there were elections at the time in December, and a lot of political violence. In the western part of Kenya, we were asked to evacuate, and there was an enormous amount of conflict, so much so that we were not able to go back for a couple of years. And then when we did, we were never able to actually get back on the same footing with new leadership and new Ministry of Health that we had previously. So we ultimately used those funds to build in Tanzania. Around that same time, we had funding to build a center in Kunming, China. We also had doctors on the ground there working, treating families, treating children. It was a little different epidemic there. When we did not create a local foundation there yet. We were not quite at that stage, but we ended up having to leave and actually pull our doctors. We had physicians with families there out literally in the middle of the night because our legal counsel in Hong Kong, Fulbright and Jaworski, said that the title that the government gave us for the building that we were going to rehab was fraudulent. And we were about to wire a large sum of money to government to take ownership of this center. And we pulled everybody out, and I was there to kind of help manage that fallout. And then so in Burkina Faso, it was really it was probably more around fraud, corruption. Kenya, political unrest, security, safety issues. China, definitely fraud, which we have a zero tolerance for institutionally. And then we had an opportunity to work in Benghazi, Libya, which we did for a number of years. There was a nosocomial outbreak there. Children had been infected through. The government had indicated it was intentional infections. They had imprisoned some Bulgarian and Palestinian healthcare workers, sentenced them to death as a result of it. Dr. Klein was called in, Baylor College of Medicine was called in to not only support the care and treatment, but to be part of a process of negotiating with Red Crescent, the Gaddafi Foundation, the European Union, and others. And so we actually started training Libyan pediatricians, infectious diseases docs there, worked there for almost 5 years, funding by the U.S. State Department, by invitation of the U.S. State Department at the time. Chris Stevens, who unfortunately has passed away during the Libyan conflicts, and we were there until the uprisings that happened in Benghazi. And so probably our failure there was more out of, again, I guess, political unrest and the health, safety, and security of our staff. So, yeah, not all of our startups, if you will, are make it to the goal line, but not for lack of trying. Yeah.
They can't all be wins.
Yeah, they can't all be wins. We'd like them to. And I think there are opportunities that could arise in the future that could put us back in some of those places. Yeah. I would hope so. Yeah.
And those are different reasons in each instance that you mentioned, but what sort of lessons do you think were learned from those failures that helped instruct BPI on its approach to global health and the way it continued to work in very different countries on the continent, and then also, of course, in South America?
It's a great question. You know, we are not a rapid response, emergency response institution or program. There are others more suited and whose mission is to do that, including, Red Cross or Doctors Without Borders. So our programs, our partnerships are usually much more strategic, informed by invitation typically, and we make informed decisions. And there are a couple of things that we will never deviate from, and that is there's a zero tolerance for graft, corruption, malfeasance by governments or other institutions. If we feel that there's a higher risk of that, we'll mitigate that risk by just not even putting ourselves in a position to have to be put there. The other that we will not deviate from is any place that we feel that the health, safety, and well-being of our faculty, our staff, our fellows, our personnel would be in some way jeopardized, and we won't do that. If we're in a country and we feel that they're at risk, we'll pull them out. If we feel that there's a risk going in from on the front end, we will typically not. We will avoid that. But but for the most part, we approach our partnerships very with an open mind, and especially when we're trying to deal with and address pediatric and family health inequities, and if it's an area or a country that we simply can't operate in due to those issues, we'll do the best we can to find someone or help the countries find someone that potentially could. Yeah.
I want to make sure we talk more about PEPFAR. I have so many questions, though. Prior to PEPFAR, early American government initiatives largely focused on mother-to-child transmission, and was BPI is a pediatric AIDS initiative paying? What sort of attention was it paying to those efforts? And then how did that impact the work that y'all did? Because I imagine there's a relationship between the two issues, obviously.
Yeah. I think Dr. Klein's vision in creating our Children's Clinical Centers of Excellence was to address the lack of appropriate infrastructure to put trained pediatricians knowledgeable in infectious disease and HIV on the ground to help build local capacity through education and training, and to ensure that mothers are getting tested, and more importantly, that children who are positive are getting access to antiretrovirals, and then also to enhance and build education and training, obviously on best practices around pediatric care and treatment, and then very strong and robust monitoring and evaluation systems to collect information that could be used to help drive policy, data-driving policy. The mantra for BPI early on was that we were not a research enterprise. We were there to provide care and treatment. That was our focus. That was our mission, to provide high quality, high impact care and treatment and prevention services. And Dr. Klein would often say, children on the African continent are not dying from lack of access to clinical research. They're dying from lack of access to care and treatment. So we wanted care and treatment to be really the pillar of care, the pillar of our mission, and operational research could be a byproduct of that to help improve quality of services and to drive policy, not research being the core pillar, and then care and treatment is a byproduct of that research. The protocol ends, the care and treatment ends. So our focus was getting children tested on antiretrovirals, moms on antiretrovirals if they weren't already, and that was really our key focus within our children's centers of excellence, and then using our physicians to build local capacity with medical officers and ministries of health. We had other partners that would work side by side with us, whose charge truly was the PMTCT side of the continuum, which going out, identifying men, women, testing them if they were positive, getting them on antiretrovirals, if they was part of prenatal care, antenatal care, getting them tested, getting them on regimens to interrupt HIV transmission, et cetera. Our centers were all outpatient. We intentionally created outpatient centers because they were. But we just felt that if we created those and we were effective, inpatient census in the hospitals would ultimately go down. And most of our centers around the world were actually built on hospital campuses by designation of ministries of health. And so we were able to then, you know, cross-pollinate with inpatient, outpatient services, medical staff, et cetera, a pretty seamless continuity of care. So other partners that we worked with, Elizabeth Glazier, Pediatric AIDS Foundation, or EGPAF, ICAP, or the Columbia projects, which may have had more focus on prevention of mother-to-child transmission, would be we would work shoulder to shoulder with them on then helping and receiving mothers postnatal and caring for those children. Our centers were also we treated the entire family. The HIV infected child was typically the point of entry into the clinic operation systems, but then we would treat the entire family regardless of HIV status. So they quickly became more holistic family-centered care and treatment systems.
And you've talked about how PEPFAR funds initially helped y'all identify where you might spread out into as far as BPI centers go. But can you talk about how PEPFAR funds affected BPI beyond that?
Yeah, as I indicated, PEPFAR. So our 2024, our network of affiliated foundations and clinics, our network budget is $105 million. Probably 60% of that was in some way was direct or indirectly PEPFAR or USG funded to those local foundations. So PEPFAR has had over time has become, even in countries that were not originally identified as a tier 1 country, its reach and scope has a touch point on in every country that we operate in that has some focus on HIV/AIDS. So maybe with the exception of Romania, PEPFAR has not been an issue for us or a source of funding in Romania, but all of our touch points in sub-Saharan Africa have. And so we over time have utilized the resources from PEPFAR extensively. And the reason that's important is I'm going to use Malawi as an example. Remember, it was a country that we knew going in that we would have to find resources. And so we were privately funding operations of our clinic there in Lilongwe at Kamuzu Central Hospital through the Abbott Fund, through UNICEF, Global Fund, other sources. Because we had created a pretty robust organization there, we were able to identify and secure direct funding from PEPFAR, USAID, and through a couple different mechanisms, and actually probably that foundation is the largest recipient of U.S. government funds on a singular grant of any of our foundations, and actually more so than Baylor College of Medicine itself. And that speaks to its ability to manage and to achieve the directives, milestones, goals, and objectives of PEPFAR funding. However, when those funds diminish, or if in fact they become jeopardized, or the grant, we don't compete and those funds go away, our ability to still maintain the organizational capacity through private donations, private philanthropy, through Baylor, through Texas Children's, and the diversity of other services within Malawi, our pediatric hematology program, sickle cell, cancer, our OB-GYN, women's health, cervical cancer through private funding with Bristol Myers Squibb, et cetera. PEPFAR has allowed us to actually strengthen the foundation of our foundations, if you will, no pun intended, so that if those funds are diminished or if they even go away in the future, it's allowed us somewhat of a bedrock to maintain the organizational structures, the personnel, leadership, and systems that the investment has made possible. And that can't be taken away. And it's one thing I think we should be very proud of, is that there are there will be some everlasting systems and organizational foundations and even infrastructures that have been developed through our PEPFAR mechanisms that I'm confident will be able to be sustained and maintained through other funding mechanisms.
Mm-hmm.
Our foundations being those as well.
Mm-hmm. This goes back to the strength of the public-private partnerships that you talked about.
We hope so.
Yeah.
We hope so. Versus just the public partnership, and in some cases the public side, Lesotho, Botswana, Eswatini, the public side was local government, not U.S. government, and that actually has allowed us to have even a greater degree of insulation from funding uncertainties that seem to be. It's just part of global health. It's a very fluid landscape, as we all know that work in this space. Yeah.
And I'm thinking about private support for programs such as BPI, and it's sort of an embryonic question, but I'm thinking about your work in Houston and the stigma that actually led to your accepting the job at AFH, and working in HIV/AIDS treatment and prevention when it was considered to be a disease that a virus that affected just the gay community or people who are ostracized in some way or another. And then you shift to pediatric HIV/AIDS treatment. Can you talk about working in pediatric HIV/AIDS after working in Houston in that regard? The sort of differing backdrops there and how people thought about HIV and the population who was suffering.
Yeah. At AIDS Foundation, and probably no different than at BPI. And I think this goes just as part of human nature. Disease and conflict and social issues that negatively affect children, they impact people. I think they have a different. It resonates differently, I think, with folks than when you're talking about adult populations for whatever reason it is. It's just oftentimes it's perceived or felt as if it's with children. It was not they're innocent victims, for lack of a better term. And that's not my term, but I've heard that over the years. They didn't choose to get this disease, or they didn't choose this situation, or whatever. And we and there seems to be, and we have, and we see that in other issues, even in our world, in space, in sub-Saharan Africa, around pediatric cancer and other situations where there may be physical deformities or situations that put children that they're suddenly ostracized or seen as something different. And I think we as a society tend to take pause and are a little bit feel a little bit more maybe compassionate towards children in situations and sometimes adults. And so for that, um, fundraising can be uh, helpful in helping us address pediatric issues that some individuals might not feel comfortable giving funding for if it was an adult situation, meaning pediatric HIV. Someone may be much more comfortable in giving us at AIDS Foundation money for Camp Hope to support children living with HIV, and they would never consider giving us an unrestricted donation to support our social services for adult populations. And I think from a philanthropy standpoint, that may be the same when it comes to some of our pediatric services, and that's a pretty broad statement, but it I think it's a valid point, and but I think from a clinical perspective, it has continued to be a challenge. I think the one of the challenges we're going to have on our pediatric side are the children that we were taking care of in the early days of in the embryonic periods of our network, of our foundations. Romania, Botswana, et cetera, is prevention of mother-to-child transmission has improved. In Romania, our children are adults. We're dealing with an adult population actually who are now having uninfected children. And so have we succeeded in our mission? Have we achieved what we set out to do, which was to save the lives of children? Possibly, but now we have children that are adults, and it's a whole different way of trying to find support for a program that folks feel, well, I gave to you and supported you to save these children. Now they're adults. We're going to move on to another issue. I think in Botswana, and this really speaks to, I think, our what has PEPFAR allowed us to do and achieve. You know, I talked about President Mohi in 2001, the UN General Assembly indicating that we're threatened with extinction, and 20 years later, World AIDS Day 2021, the World Health Organization announced that Botswana was the first high-burden country in the world to achieve a silver tier status around prevention of mother-to-child transmission, meaning less than 5% vertical transmission, mother-to-child, and 90% of women as part of antenatal or receiving antenatal care, testing, and put on antiretrovirals as part of their prevention efforts. That's 20 years, and we've turned the spigot off. We're Camp Hope is going out of business. We're not having children coming to camp, and they're hitting their milestones of 95% of people knowing their status, of those 95% on antiretrovirals, and of those 95% have viral suppression. They're surpassing that. The country with the highest prevalence in the world, it was threatened with extinction. Now it's the gold standard in the region. So those are the type of accomplishments that we would never have been able to achieve without PEPFAR. I'm convinced of that, and I think you'll be hard pressed to hear anyone say differently. Those resources and the commitment by of partnerships and willingness to work together to try and achieve those milestones. I think we're going to see other countries in our network hitting the same and similar milestones in the years to come.
Mm-hmm. We're winding down.
Yeah.
this is a broad question, but how do you find PEPFAR influenced your thinking about public health and global development? And asking this knowing that you were in these fields before PEPFAR was announced, but thinking about that shift in funding and the differences that you saw on the continent after it was implemented.
Um, I think it has definitely allowed me to really think a little bit more broadly around partnerships and the importance of um, our engagements with ministries of health and ensuring that our partnerships with governments are sustainable, that we manage our expectations around what resources we have and are willing to bring to bear. And I'm talking about us institutionally, Baylor College of Medicine, Texas Children's Hospital, and that we fulfill our commitments and obligations that we have around our programs. I believe that with PEPFAR, it has really strengthened our resolve around ensuring that as we go forward with public-private partnerships, that we continue to do what we've done best, and that is in engaging our local governments and ministries of health as our primary partner, ensuring that there are resources that can be brought to bear by our government partners in the event that on our side, the U.S. government side, if there is any diminishing of resources, whether they're financial or in kind, that we're in a position to be able to maintain our programs and our services so that we can ensure some degree of continuity of care. And it's helped me understand and appreciate really the strength of local engagement and local resources to maintain our programs.
Mm-hmm. It's interesting to me that that's always been BPI's approach when that was such a big part of PEPFAR as well, was this local engagement. It seems like y'all were really primed to
Yeah.
For longevity.
And like I said, it's not like we had a crystal ball. I think that was just inherently, it was our approach. It was Dr. Klein's approach. We embraced it. We all did, all of us as leaders within our institutions, and we continue to this day to embrace that approach. And it seems to be helping us weather some of the storms that have been about of late. Yeah.
Mm-hmm. Reflecting on your work with PEP in regards to PEPFAR, but also more broadly with pediatric HIV and AIDS treatment, how do you feel about it? This has been a big part of your career.
Yeah, I have to say that I'm proud of the work we've done. I'm proud institutionally of the organizations I've worked with. I mean, I've worked basically. I've had 2 jobs my entire adult life, and they've both been in HIV/AIDS. At the foundation for 17 years, and now 21 years at Baylor, and I've had great leadership and our institutions that I've been fortunate enough to work in. It starts at the top. It's leadership that filters down to the top, and I wouldn't be sitting here having this interview if it wasn't for the collective group of people. It's all about team. It's not me. It's not Mark. As individuals, we're very fortunate. I feel very fortunate to be part of a team effort, of a group of very dedicated, committed people, not only in our institutions, but globally, in every country we work in, our leaders on the ground. And I have to say, I would be remiss if I didn't acknowledge that many of us in this field who travel a lot, who spend more time away from our families than not, or who end up picking up and moving to countries to be closer to the provision of care and to our jobs and living in foreign lands with our families. We can't do this without the support of our families. They've made sacrifices that I think often go unappreciated and definitely unseen by those around us. And I wouldn't be able to have pursued my career beyond AIDS Foundation if it wasn't for the support of my family, and especially my wife and son, who, you can't make up for the years of lost time that you're not away. And I think that goes for a lot of people in the world that have been part of this experience, this PEPFAR journey, that have made commitments, lifelong commitments to serving communities and institutions. But their families have been part of the journey as well. And I want to acknowledge all those that are part of the other individuals whose family partners, spouses, children, friends, colleagues that have been part of this, because that's what keeps us going, allows us to keep doing what we're doing. So shout out to all those folks. They're not being interviewed, but they should be remembered.
Yeah, of course.
And appreciated. Yeah.
And your son, you mentioned, has gone into medicine, so who knows how your work maybe has directly or indirectly.
I can tell you, if he was sitting here, he'd tell you global health. I've been there, done that. No, I'm going to stay in the U.S. But he's gotten to see the world and a lot of Africa over the years that we lived in, and Malawi, and working in a lot of the places that we did. So it's a great learning opportunity, and he's well versed in the history and the HIV disease and its impact. So unlike many young people who it was something, that was back then and not really resonating today.
Yeah, that's interesting. I haven't really thought about it that way. But
well, yeah, I mean he's 31, and he'll tell you that there aren't many folks in his age that really were impacted by HIV. I mean, I work with folks that weren't even born into the early days of the epidemic. So it's a different time with antiretrovirals and PrEP, and being a chronic manageable disease. We don't hear about it as much as we used to, and I think that was. That goes as part of our, the pandemics and other places outside the U.S. So.
Yeah. Many Americans, and I swear I'm nearly done here. Many Americans don't know about PEPFAR, don't recall it, don't understand its significance. Some combination of the two, but it was huge. Why? What do you think what do you think explains that sort of gap in knowledge? And what is the importance politically and socially of understanding in 2025 what exactly PEPFAR did and how groundbreaking it was?
Yeah, I think to the point I was just making, I think we in the 80s and 90s, I think AIDS was very much front and center in the American public culturally. I think it was driving policy and in health and human services. I think in finding drugs and drug therapies and saving lives, it was very much. It was part of our cultural fabric in the United States, I think, and in Europe. And when PEPFAR came out, it was in the early 2000s, 2003. we were the disease, how we were seeing it manifest in the U.S. was changing more to that of hope, and manageability and access to drugs, and people living what we call the Lazarus effect of, men and women, adults, who were sick but now well and not dying but living and going back to work and thriving, and it became a very positive environment, I think, to be living with HIV in this country. And I'm just speaking from many friends I have today that are long-term survivors, long-term individuals who've been living 30 plus years with HIV and doing quite well. And PEPFAR rolled around to provide an emergency plan for AIDS relief, as it says, and I think because it was a foreign concept, and I mean that because it wasn't a foreign place, and we were providing resources and funding to other places in the world. And I think it's sort of that out of sight, out of mind aspect of doing a lot of good. And we probably didn't do as good a job as we should have around promoting how good we were in dealing with this and addressing this globally. We did not. Institutionally, we didn't, but we don't toot our horn.
BPI.
BPI didn't, Baylor College of Medicine, Texas Children's. We weren't about trying to. We didn't do what we did for the sake of glory or praise or front page news or whatever. We did it because we had an obligation to do it. I think a lot of institutions and organizations felt the same way, and for good or bad, I just don't know that the general public ever really understood or even acknowledged that what PEPFAR was, and not only PEPFAR, but if they did understand it and you talked to them about it, that it was under George W. Bush's administration, which I think takes some people aback, even more so than the fact that we've done this great humanitarian work around addressing HIV, AIDS, malaria, tuberculosis, and other things. So, I grew up here, multi-generations of Texan family, and unless you work in the space, most wouldn't have much understanding or knowledge that we've been doing this for so long and around the world.
Well, is there anything you feel like I've missed that you want to discuss, whether it's about PEPFAR, BPI, anything else?
No, I just thank you, for the opportunity to do this interview, and all the others before me and after me that are being interviewed. I think it's definitely worth the time and energy to put this on record. So great things that we've been able to accomplish through this initiative. And I'd like to thank President Bush himself for his commitment in making this happen. He continues to be a staunch advocate for this, as well as cervical cancer initiatives, and greatly appreciate his advocacy on this.
Well, thank you so much for your time. I appreciate it.
Thank you.